Good morning, everyone, and welcome to the 2024 Ohio Early Intervention Forum. I am Erica Wallace, the Children and Families Advisor at OACB. On behalf of the Ohio Association of County Boards, we are excited to welcome you to this year's forum. This is a special opportunity for all of us to come together with our shared commitment to the growth and development of Ohio's youngest and most vulnerable children. Today's agenda will begin with an introduction from Director Wente from the Ohio Department of Children and Youth. Following Director Wente will be CEO of OACB, Adam Herman, with a welcome introduction as well. Then we will begin the first session of the day with Early Intervention Hearing Vision Checklist Overview, presented by Jenny Remeis, Jackie Lucy, and Karen Kincaid. The second session of the day will be Building Bridges, Leadership and Relationships in the EI Team, presented by Susan Jones and Beth Poppich. The third session will be Uncovering the Roots of Behaviors, Sensory Challenges, and Delays, presented by Danielle Nelson. And lastly, the fourth session of the day will be on Safety Protocols for Home and Community Visits, presented by Willie Jones. Thank you all for your dedication, your passion, and for being here with us today. We look forward to a successful EI Forum. I will turn it over to Director Wente.
Good morning, everyone. I am so excited to be with you all today. For those of you I haven't met yet, I look forward to hopefully connecting with you over the next year. For many of you that I have gotten to know over the last year, it has been a pleasure. I want to just start, though, by saying thank you for your patience. As we transitioned to the new department, I know there were questions and uncertainty, and certainly we still continue to work through those. But you guys have been gracious. You have been helpful in providing guidance and solution-oriented. I really appreciate the fact that when you all as an EI team come together, it's highlighting maybe things that are concerning you, but there's always some type of suggestion that comes behind it, which makes it feel like it's something we can fix. And I can't tell you what it means to have partners in the community that are standing at the ready to better serve and do what's right for Ohio's kids. I had the pleasure over the last year of engaging with about 700 community partners and about 270 families. And the one thing that I actually just shared last week with the team is every time early intervention came up, the parent said either, I wish I would have found it sooner, I don't know what would have done without it, or I'm just so grateful for my care coordinator and the services my family received. Every time early intervention comes up, it's a positive story. And when other families hear those positive stories, they quickly say, how do I have that same support from my kids? As a mom, I know that I went through the process and I recognize the value that it would bring to my son. And I just want to say thank you for all you're doing every day to do what's right for Ohio's kids. I look forward to partnering with you as we prepare for the 26-27 budget and really focus on improving Ohio's infant mortality rate, on ensuring more kids are ready for kindergarten, and reducing the number of kids in foster care. Certainly, I recognize that you all play a critical role with early identification and stabilizing that family and meeting those family needs in every one of those goals. And I look forward to partnering with you as we continue forward. Have a great session today, and thank you for all you do.
Well, thank you, Director. We appreciate you being here, and good morning, everyone. Thank you again for joining us here today for this year's Early Intervention Forum. We know how demanding your normal day-to-day responsibilities can be, as Director Wente mentioned, which is why we're so thrilled that you've chosen to spend what little extra time you have here with us today. As you all know, this year has seen big changes in our field, as early intervention made the transition from DODD to the Ohio Department of Children and Youth. And as you just heard from Director Wente, there are incredible opportunities in the near future related to early intervention and kids in general, especially now that nearly all programs supporting kids are finally under one roof at the state level. County boards see firsthand the challenges faced by kiddos and their families as they navigate the various systems in Ohio that are designed to support them. But we haven't always had the ability to overcome what gaps in service exist outside of our influence. With every department and agency at the state level holding its own unique piece of the puzzle, the challenge seemed unsolvable at times. Though it never stopped all of you from coming up with new and creative ways to fill these gaps wherever you could. Now that Director Wente and her team are in place, we are confident that these bumpy transitions and overlooked responsibilities will soon become a thing of the past, and we are grateful for the personal leadership she is demonstrating to help us achieve this goal. In fact, over the past 18 months, Director Wente and her team have engaged with OACB and many of the people who are in the audience here today about the best path forward for kids served by county boards, really more than any previous administration. Their team's commitment to doing the right thing by kids is clear in all of their words and actions, and we're fortunate to have them as partners in our shared mission. Next Wednesday, we'll meet again with Director Wente in person to discuss how we can take early intervention, preschool, and multi-system youth supports to the next level in the coming two-year state budget. It's an exciting time to be supporting kids in Ohio, and we're thrilled that all of you are being asked to sit at the table to help create a better future for those with the greatest level of need. Before I go, I would be remiss if I didn't share just how continually impressed we are at OACB by the level of creativity, the problem-solving skills, and really just the unrelenting dedication that this group demonstrates on a regular basis as you fulfill your responsibilities. There is no problem too large or too complicated that can stand in the way of ensuring our most vulnerable kids get the support they need at the most critical time in their lives. And we're proud of the fact that your work has such an incredible impact in the lives of the people that we serve. County boards are making a profound difference in the lives of kids with disabilities in this state, and we all have all of you to thank for it. So thank you for all that you've done and will continue to do, and for being here with us today. We can't wait to see what's coming next. So with that in mind, I'm going to turn it back over to Erica, who's going to get our first session started. Thanks again, everyone, and I look forward to seeing you again soon.
Thank you, Director Wente and Adam, for those introductions. We really appreciate your time this morning. So we'll get started with our first session, which is EI Hearing and Vision Checklist Overview. I'm going to read the bios for the presenters this morning, and then we will get started. First, we have Karen Kincaid. Karen has worked as an Ohio Early Intervention Regional Program Consultant since 2017. She has a Bachelor of Arts degree in Child and Family Development from the University of Akron and is a licensed social worker in the state of Ohio. Karen is credentialed through the Ohio Department of Developmental Disabilities as a developmental specialist and is certified through the Family, Infant, and Preschool program as a Fidelity Coach. Karen has more than 23 years of experience working in the field of EI. Prior to working in EI as a developmental specialist and a certified play project consultant, she worked as a service coordinator for Help Me Grow and in the field of child welfare. Our next presenter will be Jenny Remeis. Jenny is the Assistant Administrator for Early Learning Services and Statewide Coordinator for Early Intervention Vision Services at Ohio Deaf and Blind Education Services. She has a bachelor's in special education from Ohio Dominican University and a master's in visual impairment from the Ohio State University. Jenny has over 26 years of teaching experience, which includes special needs preschool, middle school students with multiple disabilities and blindness, orientation and mobility training, and her current role in early intervention. Our last presenter for this session will be Jackie Lucy. Jackie Lucy is a speech-language pathologist on the Early Intervention Hearing Services team from Akron Children's Hospital. She received a Bachelor's of Education in Speech-Language Pathology and Audiology from the University of Toledo and a Master of Arts in Speech-Language Pathology from the University of Akron. She has provided early intervention services to the children who are deaf and hard of hearing for the last 22 years, with the last 8 years being on the EIHS team. She has also provided center-based, individually designed therapy for children who are deaf and hard of hearing, participated on the Summit County Help Me Grow evaluation and assessment team as an SLP, and provided practicum experience to graduate students. With that, I will turn it over to Karen to get started on our first session of the day.
Good morning, everyone. Thank you for letting us join you today. And with me today is, again, Jackie Lucy and Jenny Remeis. I'm going to start going over a review of the guidance that we just sent out. Sorry, having a technical issue. That we recently sent out is also located on our website under the Providers tab in the Forms section under Eligibility, Evaluation, and Assessment. If you are unable to find this or did not receive it, please reach out to your program consultant. Later on, Jenny Remeis will be going over the vision checklist, giving information regarding how to assess vision, and just kind of giving you a better idea of what those items are on there and what to do with them. And after that, Jackie Lucy will be going over the items in the hearing checklist and providing information on how to assess hearing. The checklists were created as a way to assist qualified personnel. It's a way to assist qualified evaluators and assessors with gathering hearing and vision information. The checklists bring attention to prior screenings or exams, diagnoses, and syndromes that are risk factors for hearing and vision issues, as well as observations. We updated the checklist based on feedback and challenges that was shared with the state team. Why do we assess hearing and vision? It is a requirement of the federal government that hearing and vision are assessed during evaluation and assessment. This is not a new requirement. If you look on the old IFSP in Section 3B, the narrative states that hearing and vision were included in the physical section. Throughout the last 5 years, we saw this addressed in a multitude of ways, from nothing being mentioned about hearing and vision to information that they just passed their newborn hearing screen to there were no concerns. The checklists were created to give some consistency to how children's hearing and vision are being assessed. So we created some new guidance for how to do this, and we received a lot of questions regarding when these needed to be done and who should be doing them. So every child must have a hearing and vision checklist completed during their initial 45-day process as part of their initial evaluation, or if they're eligible, their child assessment. Then annually, every child must have new hearing and vision checklists completed as part of their annual assessment. This is regardless of who is the service provider. Qualified personnel must complete the entire checklist. They are responsible for gathering the information as well as documenting it. All that good, rich information is then documented on the hearing, on the evaluation summary section and on EIO3. And we will be sending out some examples of what that looks like this week. And that happens when an evaluation takes place. And then on the IFSP for every single child on section 3. So now let's talk through the 4 steps on the guidance document. So our service coordinators or other intake personnel, they provide a really important role in getting to know that family and gathering and collecting some really rich information and then sharing it. So as they were going through their initial phone call or home visit with that family and gathering all that information regarding any hearing or vision concerns, if the child sees any specialist, such as an audiologist, ophthalmologist, or optometrist, and then if they do, what were the results of that visit? And then sharing all of that good information with the team. If they are aware that the child has been diagnosed with a syndrome or condition, that information is also shared with the team. The next step, step 2, is involving the core EI team. The core team uses the information shared by the service coordinator to determine if a hearing or vision provider should be considered as part of the evaluation or assessment team. This should especially be used when the child has a confirmed or suspected hearing or vision diagnosis or syndrome, or the parents have expressed that they have a concern for hearing and vision. So then step 3 is about the evaluation and assessment team. When they're conducting the evaluation or assessment, they're also gathering information about the medical history and reviewing any medical records. They complete both the hearing and vision checklists. Most of the information needed for the checklist can be obtained during the evaluation and/or assessment. Any remaining information should be acquired through a parent interview. Information for the checklist are documented in the evaluation summary section on EIO3 if an evaluation was completed, and on every child's IFSP in Section 3. Step 4, determining next steps. This is where we made the biggest change to the process. The EI team is analyzing all the information and they determine the next steps. Before we had that if anything was checked, it had to go to your hearing or vision person. But now we're asking the EI team to analyze all the information gathered and then determine what next steps need to happen. So does the child need to be presented during the team meeting? The E&A team uses that information gathered to determine if they need to share all of the information with their hearing or vision provider. If so, they need to share that information, if the hearing or vision person will be at the next meeting, then the service coordinator sends all the information to the hearing or vision provider prior to the meeting, and the child is added to the agenda. If the team meeting that your hearing or vision person will attend is a couple weeks away, you can reach out to them to consult with them either by email or phone. Remember, you can move forward in the process with the additional steps needed in the IFSP process while you're waiting to hear back from your hearing or vision person. They don't have a timeline to respond, so please continue moving forward with what you need to do. The next piece is they determine what other next steps. So this could be coaching. Just like the PSP can request to add a child to coaching, so can the E&A team. Coaching may provide information about the diagnosis or syndrome, how that may affect hearing and vision. It may help to develop some strategies for the IFSP or determine who should be the PSP or the SSP. The E&A team may determine that they need to request a consultation with the hearing and vision person. Or they may just need to do some additional recommendations, such as recommending a hearing test or a vision exam, or referring to additional professionals. If your team does not have a hearing or vision provider who attends your team meeting once a month, please reach out to your consultant. So I just want to finish up with some additional hearing and vision guidance. The service coordinator is responsible for ensuring that the checklists are completed by qualified personnel, as well as making sure that information is captured in the evaluation and assessment information. Once all of the components of the evaluation and assessments are completed, including both checklists, the team can move on to an initial IFSP, even if you're still exploring additional steps needed with the hearing and vision providers. If the team has assessed that additional medical follow-up is needed, the service coordinator or the E&A team must recommend that the family make an appointment for further evaluation. Information gathered on both checklists are documented in the evaluation summary on O3, if an evaluation was completed, and for every IFSP in Section 3. Information is not documented within the EIDS system. And one last thing, if the last box is checked with that has a list of syndromes, please specify which one of the syndromes in the optional notes section box in the assessment analysis section. I will now turn it over to Jenny Remeis to go over the vision.
Thank you, Karen. All right, I'm going to pull up my PowerPoint. There we go. Okay, so Jackie and I, as Karen said, we're going to go over each of the checklists, vision and hearing, separately because they're very different. And you'll hear a little bit or learn a little bit more about why that is as we go through. So with vision, and hearing, ultimately, the goal of these checklists are to just be that additional tool, like Karen said, so that we're able to make the most informed decisions when we're determining what types of services families are going to need. So we want to make sure that we're including all those areas of development in the assessment and evaluation process, and then bringing that back to team so that we can decide who is going to be the best members of that child's IFSP team if they're going to require services. And I know all of this is a little bit daunting. So our goal here is to just break down each individual section of the actual checklist, give some ideas of what you might be finding yourself putting there. And then at the end, we'll gather questions. And if Jackie or myself cannot answer them, Karen will. And then also she will take anything additional back to the team to discuss. First, on the top of the checklist is that prior vision screening or vision evaluation. And this is information that is going to be coming from a doctor. So it's not, I don't want, or we don't want the date that you are conducting the checklist, but it's information based on, have they been to an optometrist, an ophthalmologist? And if so, when was that conducted? We want to know where that was conducted. If it was, that kind of gives us a little bit more information about what may have happened in that visit. The doctor's name, and sometimes obviously the families aren't going to be able to recall some of this information. So whatever you can find from them or whatever they're able to tell you is obviously going to be what we're hoping to gather. And then the recommendations. And so if they have a diagnosis or if there's been follow-up, you're going to put that on there. I do want to make a note about any families that are seeing doctors at Nationwide Children's or Cincinnati Children's or any of the children's hospitals. Their pediatric ophthalmology offices oftentimes are separate offices that are just within that space. So they may not be sharing the same MyChart system. So just letting them know that when they're requesting records, they might have to do that in a different way from those agencies. And so when you're filling out the EI-6, make sure that you put pediatric ophthalmology on that EI-6 form if that is where they went. And then I have a did you know? So did you know that there's actually no universal newborn infant hearing screening? Is a hearing screening, not a vision screening. So newborn infants, if they are not premature, there's no screening that is done in the hospital. So oftentimes we're not receiving diagnoses until much later, and we're missing that. Another reason why they're going to be really the only exception to this is those children who are born prematurely, and it's any child who's born below 30 weeks is at extreme high risk for retinopathy of prematurity. So any child who is born premature is going to be screened for retinopathy of prematurity. And so you would include any of that information, but otherwise we're really not getting any information about vision at that newborn level. So it's really important that we find out as much as we possibly can. The next section that you come to on the checklist are the risk factors for visual impairment. And so, as I said, with the premature infants, we're really looking at that ROP. And there's different levels of retinopathy of prematurity. There's different stages. And so when we look at where it's a stage 1 or 2, oftentimes those resolve. And so we're wanting to know that information. Anything from 3 to 5, oftentimes children will receive surgeries to try and correct that. And then, we're again watching to make sure that they are not having any additional vision loss, because that can be a high frequency with kids who are 3 to 5 on that scale. The information that I have checked off here in yellow: intrauterine drug exposure, meningitis, encephalitis, stroke, cerebral palsy, hydrocephalus, hypoxias, seizures, head trauma, any of these that involve the brain are going to put a child at high risk for developing a neurological visual impairment. You may have heard the terms cortical visual impairment, cerebral visual impairment. Sometimes doctors might put cortical blindness, and often in the initial stages, it's listed as delayed visual maturation. And it's not unusual for these children to have been seen by an ophthalmologist or an optometrist and been given a clear bill of health in terms of their eye health. So it'll say, yep, there's no visual, there's no issues with the eyes. So because of that, families might not have vision on the radar. And that's because these are visual impairments that happen within the brain. And so we find these diagnosed conditions most often with neurologists and ophthalmologists. And they typically aren't giving that diagnosis oftentimes until after 9 months of age. But we know that all of these highlighted areas are putting a child at extreme risk. And so we really do like to jump in there as soon as possible so that we're helping the families and teams to develop appropriate strategies and also preparing them for those visits with the ophthalmologists, neurologists, so that they are understanding what they may be hearing and able to interpret that. And so these risk factors are just really to help you be more aware of what might lead to a visual impairment so that we can have these conversations during our team meetings. And I have a did you know? So did you know that there are over 350 hereditary eye diseases? So obviously I don't have 350 labeled up here. These are some of the most frequent or common situations or conditions that can cause visual impairment, but there's a lot of others. So we want to make sure that we're highlighting these that we have here. There's also a list that we have shared with many of our counties that has a more extensive things on there that you might see on a child's medical report. And so I did share that with Erica, and she's going to be adding that to the Padlet, so you can refer to that as well. So then that next piece that we get to are the behavioral observations. And as you look through these, it's listed by 3 months. And this is, we're looking at typical development. By 3 months of age, we should notice a child smiling at others or watching their own hands. You're going to obviously be filling this out like you would any other developmental checklist. So you're going to be looking at the developmental age where that child is currently functioning. And that's where we're going to start with all of this. So a couple of highlights that I'll hit on here. The one with looking at a rapidly moving object. I think that is, yes, on 12 months. So this is looking at a rapidly moving object. So this would be if something's being tossed across the room, or if there's a cat running across the room, anything like that. We're noticing, do they recognize that movement because it's moving so quickly? Sometimes that can be hard to process for a child who might have some visual processing difficulties. At that 18 months, we see identifying a family member at a distance. With that, we want to make sure, are they identifying them because they're seeing them and recognizing, or is it because they hear their voice? So those are two different things. And we want to make sure that the family understands, with their voice off, does your child recognize who you are? And again, with any of these behavioral observations, if you have questions about these when you're filling them out, this is an excellent opportunity to bring this up during team meeting when your vision provider's there, and we can dig more into this and give some suggestions. So this is then a continuation of that with the 24 months and 36 months of what we should be seeing. And again, these are just highlights. This is not everything that you will see, and that's why those observation boxes are at the end so that you can add anything additional that might be helpful. As we go into observations of the eyes, this is going to tell us a little bit more about, do we really think the eyes are involved, and should we be involving someone to help us with this, or recommending that that child be referred for an ophthalmology appointment. One of the things that I would like to just highlight on here is that accurate reaching for objects. So that's really a visual behavior. And we're wanting to know, do you notice if they're reaching above something or below or off to one side? Because that can tell us that there's some depth perceptual issues. And again, that's just something that we can help with coaching during our team meetings. Okay, finally, we get to this assessment analysis. And so here, you're going to be checking those boxes to see if they're, yes, they had a prior vision screening and there were concerns, or no. Have you checked those risk factors? And then are there any missing skills, yes or no? And so we're going to be adding then things to those observation boxes. So we're going to break these down a little bit. The first one is that existing supports and strategies. And so here the team would note things that that they're already seeing, or if they're already seeing a specialist, if they've been prescribed glasses. This is important too. I have neurologists or ophthalmologists. And again, the neurologists are often those who are the first ones to identify a neurological visual impairment. If the child's being patched, that's helpful information. If they had ROP and it was resolved. So anything that is not going to be answered in those other questions and the family shares with you, this is a place for you to put that information in. For the optional notes, if the child has a diagnosed condition, whether it be an actual visual condition, visual impairment, visual diagnosis, or a genetic condition disorder, then those are, this is where you can write that specific information for us. And again, oftentimes we might not even know all of the syndromes or the genetic conditions that might lead to a visual impairment. And so this gives us the opportunity to do that research for you, so that if vision is a factor, then we're able to inform you of that and jump in with any assistance. You also might write some additional behavioral observations that you recognize, or visual observations. So a child staring at lights or windows. Child has glasses, but they're not wearing them. This isn't a visual impairment, but if a child needs glasses and isn't wearing them, we know that their vision's going to be affecting how they're moving, how they're developing, all of those things. Devin was shaking his head from side to side when the environment was quiet and still. So again, a child who has difficulty often will do this to make something in front of them move so that they can see it a little bit better. So anything you notice that just seems a little bit off, you can go ahead and put in there. And then finally, those ENA team recommendations. Inform the vision specialist of concern. That might be something that your team determines. Again, like Karen said, if after that initial visit with the service coordinator, the family either identifies that the vision is a concern, or if you recognize from information that you're learning about their medical background that, hey, this seems like it could be impacting vision, then we can be contacted right at the start. We can be the ones to go out as a second or even a third on that ENA team. And in those cases, we can fill out the vision checklist for you. You might find that you're asking them or requesting a referral for an eye appointment. So, and again, anything that the team comes up with is what you're going to put in that section. So here we have, when should you involve your vision provider? And this is one of those where, again, we would love to be involved from the very beginning. We want to make sure if there's something that's going to be addressed during E&A, that we're on that team so that we can do a more thorough evaluation of their functional vision. So anytime also that there's a visual diagnosis, a syndrome, a genetic disorder, it's a good idea to run that by us. Bringing it up at team, making sure that we know when it's going to be identified during team so that we can jump on there and provide any coaching. Obviously, we know that that can't always happen if we're only coming to not going to be a team, just like any other time as we are going over agendas. We might give you some initial strategies or initial things to maybe ask the parent if we're unavailable to come to the assessment, or some things to look for so we can help to prepare that E&A team a little bit better when they're going out to do the evaluations. And then in these situations, again, if you are asking for us to be a team to go over this, that would be a good time for us to see the information that you did include on a checklist if you've already done that. If the child is not meeting behavioral milestones for visual development, then that would be a good time to inform us. Checking boxes and the observation of the eyes is indicating a concern. Again, those are all times. If your family is if you or the family suspect that vision might be impacting development. And finally, if you have a concern, don't wait. So I would rather, and I know Jackie feels the same, I would rather have you come with a concern to your vision provider and them to say, oh yeah, nope, we're all good. Because at least that way we know we haven't missed anything. But we want to make sure that if there is a real concern, that we're in there as soon as humanly possible so that we're not missing any opportunities. And I have in my notes, just in terms of like being a gatekeeper, I know we have families who are so extremely overwhelmed with things going on in their lives. We all know that a good majority of kids who have visual impairments, especially those with neurological impairments, have additional disabilities as well. And oftentimes those families are just in survival mode. So I can absolutely appreciate that. In these situations, it's still really important to make sure that your vision provider is in the know as soon as possible. Doesn't necessarily mean that they're going to join the team, but those conversations can be had at the very beginning so that you're at least receiving coaching, you're receiving resources and recommendations that might be helpful to the family, so that we can get in there as soon as possible. We can also assist families by going over some of that medical information because, again, we know that they're filled with so much jargon and really daunting. I will share that a good majority of families that take children in for vision appointments often hear that their child's legally blind, and then I think that that shuts them down for everything else. So we can really pull through or help them get into the weeds with that and recognize that maybe their child has a lot of skills or a lot of usable vision, and here are the things that we can do with that, or pointing out how they can help further their development if they do have a true vision loss. So as soon as you can get us involved, it's going to be best so that we can help support you and the families. And so what happens next? And Karen went through these in stages. And so the first one is just to be making sure that you bring that to team to make these decisions as a whole team, participating in discussion during those team meetings to determine if the vision provider should be on the IFSP. So that's really the first goal of these checklists, is to determine the checklist and the assessments, really to determine who's going to be the best team to serve this family if an IFSP is developed. If the team member would like coaching regarding the checklist, they can also add and reach out to their vision provider. If we're able to jump on team meeting to do that, we absolutely will. In those instances where we're not, if it's something that needs an immediate to be addressed immediately, then we will either reach out via email or text or a phone call just to get you started. And if it's something that can wait, then we might say, let's go ahead and add this to a further team meeting when the whole team can hear this information together. Because these are really opportunities for everyone to learn, and we know that. And then from there, we'll just continue to follow that natural flow to determine if this is something that can be watched and assisted through primary coaching, or if a consult is needed to get a little bit more information and provide some additional information to the families and determine those next steps. I know I flew through that. So if you just add those to the chat box, and we'll go ahead and field those at the end. And I'm going to go ahead and turn over to Jackie.
Okay. Hello, everyone. I'm Jackie Lucy. A lot of you I know, but if not, hello and nice to meet you. So Jenny is actually running the slideshow, so this could be a little bit awkward. So I will tell her next when it is time to go to the next one. But like I said, she's running it, so I don't have control of that. So before we get into the actual checklist, and Karen did touch on this, just remember that if you do have a child that's referred to your county with a diagnosed hearing loss, which will actually most likely come out of that UNHS referral, and it goes to ODH. So that referral source is now ODH. That has changed as of, I think, July 1. But so that referral source has changed. Now you'll see ODH, and it is probably most likely coming from, they have a new parent mentor, Caitlin Rush, who is great, and is really working hard and working with families to get our numbers back up in Ohio. So again, reach out to your early intervention hearing provider to be part of that assessment. Okay, so let's move on to the checklist. And so, okay, so if you look at the checklist at the very top, you're going to have a section where it says prior hearing screening or audiological evaluation. So unlike vision for hearing, obviously we do have screenings before the baby leaves the hospital. So, and then Jenny, if you just want to click my did you know, and then yeah, I'll get to that. But so for the newborn hearing screening, all babies will have their hearing screened before they leave the hospital, and they could actually have up to 2 screenings. So if they happen to be a refer on the first screening, they will get a second one, and then that regardless will be what is recorded, what is sent to the state. So that will typically happen, before they leave the hospital. So the newborn hearing screening, or UNHS, is the first step in the national standards for early hearing detection and intervention. So the goal, so that's EDDI, the goal of EDDI is 136. So all newborns have their hearing screened before 1 month of age, again, typically before they leave the hospital. And then if they are referred then for a diagnostic evaluation, which is performed by hopefully 3 months of age. And then if they are diagnosed with a hearing loss, then intervention begins by 6 months of age. And we know that universal newborn hearing screening has significantly lowered the average age of identification of kiddos with hearing loss. So the next slide. Yep. So with that said, though, there still are a significant number of kiddos who will pass that newborn screen or rescreen, that second screen, who still are at risk for later onset hearing loss. So I think that this is, like, for us, the biggest takeaway from this checklist. I think probably all of us have yet to get this checkbox, right? It's usually pass or referred. So, and honestly, I just don't even think families probably even realize that. So the kiddo may pass that hearing screening, but that doesn't mean that they just pass. They may pass with a risk factor. So again, if we're looking at this and that child passes but has a risk factor, often the family is reporting when they pass, but they may not even know that their kiddo passed with a risk factor. So in the next section, which we'll get to in a minute, is that list of risk factors. So That list is the most common list, but the full list is outlined in what we call the 2019 Joint Commission on Infant Hearing. So the JCIH publication, which you'll hear me often say, and Erica is actually including this in the Padlet for you. It will have that full list of risk factors. So you may need to come back to this section, right? If you're then filling out the risk factors and you're like, oh, wait, they had this. So they actually did pass with risk factors. And most likely that UNH screener would have told the family this, or it would have been in their discharge paperwork, because there are recommendations that go along with those risk factors as far as follow-up testing. So we're going to go ahead and jump to that risk factor section, and then we'll go back to that top part. But I just wanted to give you an example of this. So for example, say you have a kiddo who had a NICU stay of greater than 5 days, and then within that NICU stay, right, the kiddo was very low birth weight, prematurity less than 37 weeks. So you're going to check these boxes here. So again, that would be a kiddo who, right, my kiddo passed UNHS, but they do have these risk factors. And so if you refer to that document, it's great. The whole document's great, but page 19 on that document will actually give you a chart that says, right, this right here, NICU stay greater than 5 days. This child should have a follow-up evaluation at 9 months old. And right, so that's all of the different risk factors, these plus more, and we'll give you very specific information as to when they should follow up. So the reason that this is happening, so this recommendation for follow-up audiological testing is based on the fact that our standard newborn screening procedures and protocols do not identify all children who are deaf or hard of hearing due to missed mild, neural hearing loss, progressive hearing loss, or delayed onset hearing loss. So again, these standards are set because we want to make sure that we are catching any kiddo who might have a hearing loss. So those recommendations will be made, but a lot of times families just, right, it's overwhelming, they're discharged from the NICU, or honestly, it's on their paperwork, and they're just not sure. So you guys will have access to this guidance, and that should hopefully help when you're filling this out to talk to families about that. Okay. Oh, also, and I think that actually Jenny and Karen have noted this, but so this syndrome list on here, it's a great list. It's the most common, but there are actually over 400 syndromes associated with hearing loss. So again, take a look at that publication. Okay, so let's go back up to the top. So the next box would be, okay, my child was referred. And so so my child was referred, and then from that screening, and so then they would be told to go and have that audiological evaluation. So the full audiological evaluation, the box you see here is actually the third box, but we'll go back to that middle section. So that is where, just like Jenny was saying, you would gather as much information as the parent remembers. Maybe they have the report, whatever that may look like, and you would put that in these boxes here. So for this kiddo, mom said, oh, they have normal hearing. It happened at Nationwide. I think it was an ABR. So you would fill out as much as you can. But again, just remember, even if that kiddo passes, even this follow-up, right? So say this was a kiddo that had CMV and passed that first newborn hearing screening. And then the recommendation is follow up every 3 months for that first year. And so they had then this evaluation and passed. There's, again, still further recommendations for hearing testing. So again, good for you to know. So they're still at risk. There's still risk factors. Also, sometimes we hear families think, oh yeah, I think my kiddo had their hearing tested because they saw a specialist. Well, that truly could have just been, maybe they were just looking at their middle ears, right? Middle ear function. And sometimes testing can be hard to interpret because of like Jenny had said, the verbiage that's used. So remember that, did you know your EIHS provider can support you as the team member or the family to interpret those test results, the testing itself. So yeah, so they're there to help with all of that as well. Okay, so then the next slide. So the last box would be no newborn hearing screening or unknown results. So really kind of that unknown. So maybe you have a family that has a child in foster care and they don't have results. They don't know the history. So really recommendations at that point should be based off of what known risk factors do you know, right? What's current, and then your developmental observations. And then there is the next box in between the newborn hearing screening and then that full evaluation is if there was other hearing screening. So really this would be, maybe the child had a well-check visit and that pediatrician screens hearing, or maybe they had a speech evaluation and depending where you go, sometimes that speech therapist will screen hearing. So again, this is really a screening, not an evaluation. Okay. So we already did the risk factor section. So we're going to go down to then behavioral observations. So this, in this section where you will start is really the age range that is most appropriate for the child's developmental age. And you are going to obviously check those boxes that you observed or maybe parent report or if you did used an assessment tool, you'll check those boxes. So, this list is kind of short. So, I'm sure you have other tools, right, where you're looking at a lot of these different developmental skills. But I think the biggest takeaway here too is just to remember that signs of hearing loss really can be different for different babies. And the extent of the hearing impairment can vary. So hearing can truly fool you, fool parents. And so it is not as simple as a child can hear or they cannot hear. So, we know children with minimal hearing loss or hearing loss in restricted frequencies, pitches, they will still respond to sound. They could still respond to their name. They could still respond to right voices, questions, commands, the bell, right? So, I've heard that time and time again. Well, I'm not really concerned because they turn to that bell. Well, again, hearing loss varies. So truly the best test is to get that hearing evaluated. And that really is what our standard is nationally. So if they don't respond to those things, absolutely. But even if they do, it doesn't necessarily mean they have a hearing loss. So I think the biggest takeaway, is if we're seeing some of these concerns, we, really go back to those recommendations. And it would be have that hearing checked off, check it off. They can, if we know it's not hearing, then move on and to what is really going on. Okay. So assessment analysis, this is kind of very similar to what Jenny went through. This is where you're going to put the information that you gathered and determine next steps. So was there a screening? Was there an evaluation? Are there risk factors? Are there any missing skills? So this observation boxes on the next part is, and then, yeah, you can just go ahead and click them all, Jenny, and I'll just kind of go through. But this is where you're going to put that information. So, I think this is really where this tool could be helpful because we can dig deeper, right? We could pull some of this information. I think sometimes, families aren't even aware of what necessarily is important to know. So existing supports and strategies. So this is a great section, and this example here is a kiddo that has Down syndrome. So, oh yeah, maybe here the family noted that their kiddo goes to the Down syndrome clinic. Well, most of the time we know that there would be an audiologist, an ENT as part of that clinic. So that opens that question. Oh, your child would have had their hearing tested. Oh, well, maybe they did, but I'm unsure. Again, another overwhelming appointment, but that's good information to know because then, right, there's probably some sort of testing out there. And then again, that's something that if the family can provide it, or you can reach out to your hearing specialist to help pull that information. And then, also, oh, well, we do have an ENT appointment because of middle ear concerns, right? Fluid, and maybe not even realizing, oh, well, there's another specialist that could help with that hearing piece. And then optional notes would be, this is a great section because this is where, like we said, you can note, you're checking that risk factor box of syndrome. Well, this is a great place you can note, okay, well, the child has Down syndrome, or you're checking that risk factor. They were in the NICU. Well, that just doesn't tell us a lot. So you could put how many days were they in the NICU? Did they need oxygen? Did they have feeding problems? Things like that. This is where you would put that other information. And then here in the optional notes is another great place. So, you're checking your observations, but then you can also put here things that maybe for you, oh, wow, that's a red flag, right? This kiddo didn't really respond to my voice, really delayed response to that rattle or that bell. This is a great place to note those observations and really those red flags. So, I did give Eric a handout on red flags to look for unidentified hearing loss. So again, you could have that, but this is a great section to note that. And then maybe some of those things, mom reports stuffy nose, middle ear infections, things that could lead to hearing problems. So again, the ENA team recommendations would go here. And so, we have, you're more than welcome to send that checklist. If you've checked one component or have questions to your provider, EIHS provider, I think some people have really liked getting that feedback, having that documentation. Or, if you feel comfortable looking at those risk factors, and if a family was like, oh, well, I didn't know that, I wasn't aware, please pull up that list. It's pretty black and white. It tells exactly when to follow up. And then we actually have a really nice website, Eddie Powell's from ODH, that you get on that website and you can actually put your zip code and help that family find a pediatric audiologist. So that's important, a pediatric audiologist. Or, obviously they could go to the pediatrician. So that website is actually on the checklist. The guidance. It's listed. Karen put that in the guidance to help families locate a pediatric audiologist. But again, if that's something that you want to refer to your hearing provider, they can also help you with that. Okay. Let me just make sure I had notes that I went through everything. Okay. So same thing, next box. And actually these, wait, this one's a little bit different. Okay, so when should we involve our hearing providers? So again, anytime there's a diagnosed hearing loss, believe it or not, I know evals can happen and actually you guys aren't even aware, and you get there and the parents could be like, oh, well, yeah, they have a hearing loss. And, so it could even happen during the assessment, you find out. So just regardless, anytime there is a diagnosed hearing loss, really pulling in your hearing provider. Hearing, vision, it's low incidence. We just don't know what we don't know. Same for families. And so we're really there to help you, support the team for resources and different things that are out there for these families. So, or the child has risk factors for hearing loss. So again, refer to your team, or you can look up those recommendations from JCIH. They're not meeting those behavioral milestones, speech, language, audition, or if you really, your gut, right? Some mama gut, professional gut, you feel like something's not right here, refer and we can figure out what to do. But if you do have concerns, don't wait. So yeah, so this slide is the same as Jenny's. So same thing, we really, obviously this is a team approach. And so if, you leave there and you want to, add that child to teaming, participate in the discussion for the team to hear and determine if the hearing provider should be on the plan. or providing initial feedback strategies, continue to check through coaching, or even a consult may be scheduled to review those evaluations or testing procedures. And provide coaching right for the PSP or the family on that hearing test. So yeah, so that is the checklist. And we went way faster than we thought. We weren't actually supposed to start until I think 9:30. So we went pretty quick, but I think we could probably go through some questions. I don't know, Erica, if you...
Yes, it looks like we have several great questions in the chat. So it's good that we have some extra time. Jenny, do you want to start off with the...
Yep, I can kind of go up to the top of all of these and filter through some of the vision questions. So this one's this relates to both vision and hearing. So there's a lot of questions in here of if the vision or hearing provider are already involved, do we still have to complete the checklist? So it's my understanding, and Karen, you can chime in on this, but it's my understanding that the checklist is a requirement at initial and each annual, regardless of whether or not they're already receiving services.
That is correct. Every child receives an initial hearing and vision assessment, and also at annual, regardless of who is serving the child.
Okay. And so for children that, if there's a vision provider or somebody from the hearing team on the IFSP, they can be the ones to fill those out at the annual assessments. In terms of that, you know, obviously we're always finding out additional information at those times that might be helpful. All right, let's go down here too. So I am looking, there's stuff in the Q&A and stuff in the chat box. If ROP is a risk factor for infants born below 32 weeks gestation, why is 37 weeks considered a risk factor? So I'm not, that one, Karen, you can address. So for us, we're really looking at the risk factors for ROP. And then for our extreme children with extreme prematurity, we are looking at identifying significant signs that might lead to a neurological visual impairment that often happens, and then other ocular conditions that are at risk with prematurity. So I think for those, if you have it listed as under 37 weeks, those are going to be the situations where you're going to use your best judgment of if there's no other risk factors, then maybe that's not something that needs to come to our attention. Jackie, is there anything you want to say in response to that?
Yep, I agree. So I think it's really like on the JCIH, it's really that NICU stay longer than 5 days usually encompasses a lot of those things that are happening with that prematurity. So really, yes, I think if it's just that alone, you know, no other concerns, speech, observations, parent don't have concerns, that type of thing. So I think it's really encompassing that stay and what happens then.
Mm-hmm. There's another one on here. Can parents decline to send this checklist to the vision hearing provider if they aren't interested in the service or if they've already been linked with another provider? So I think what you need to remember here is that we're part of your core team. So these are conversations that are happening in team meeting. And so if a family doesn't want services added to the IFSP, absolutely. I mean, we respect that. It's still going to be important for you as a provider that we're informed so that we can make sure that you have the most up-to-date information and assistance with strategies and recommendations that family might need. So it's not this shouldn't be looked at as we're making a referral outside of early intervention. We're within your team. So we should always be a part of those conversations when we're making those determinations. Jackie, this one's specifically for you. If the child has a hearing evaluation that indicated lower frequency loss caused by middle ear infections, and that is being addressed by an audiologist and ENT, do we still refer the child? So I
Okay,
think.
I don't see that one. So read it again. Oh,
If
wait, I see it. Okay, I see it. It's at the bottom. Um, so I would say that, you know, anytime, so whether that's information, right, that the parent is saying, or if you have that documentation, I always say just send it to us. Sometimes I think that families, might hear a piece of information, like, right, I've come in and families have said, oh, my child has a hearing loss. Well, really, they had an ear infection, but the way things are written, in reports, or the way they need to be coded for insurance. So I would say that definitely reach out. We'll request those reports, and then look at that information and make a team decision. What's going to be best for the team and the family. What kind of supports could we give you for that?
If a child has been seen by an ophthalmologist and is told that vision is fine, but we have concerns, should we recommend family gets referral to a neurologist? Again, I think this is a perfect opportunity for some coaching, some primary coaching, to talk about that with the vision provider who is on your team. Because they might give, they're going to want to have input on that, and might have some additional suggestions. And so I think that prior to making that recommendation, I think that it would be helpful to talk about that as a team together. Jackie, I don't know if you have these pulled up
Yeah,
too.
so what are some examples of screenings that would be conducted by the medical community for both vision and hearing? So screenings, just like that UNHS, it's really just that pass refer. So it might just be, I don't, not to get into all the different testing, OAE versus ABR versus, but there's these screening machines, right? That kind of just indication needs further testing type thing. So there's a handful of them. It really just depends on where the kiddo is going, but it would be labeled as screening, like if you got those results. Right? To a parent, it's, oh, they had their hearing tested. But again, another reason why, getting those results is the best thing you can do. And I mean, anybody that I work with knows that's the first thing I'm saying. Hey, let's get releases signed and let me get those results. And usually it gives me way more information, and then way more supportive for the team when working with the family, because it's just, some of that verbiage and understanding it can be difficult to understand. So I just think on that checklist, it's just when you're filling it out, right, being able to that UNHS, everybody has that's that screen, but that next box is really the difference between if they were just screened again versus actually having a full evaluation, where they're going to have all of that testing done. So.
And for vision, so at the pediatrician office, they do, again, have some different types of screening equipment that they can look to check. Sometimes they can get the prescription to determine, or they can look to see if a child is appearing nearsighted or farsighted. They can see some concerns with eyes that would indicate potentially like an eye cancer, or additional structural issues that they would then refer to an ophthalmologist or an optometrist. So those, again, are not conclusive, and they're not going to give us that full scope of information. So if there's a concern that's brought up by a pediatrician who's done that, then that next step would absolutely be, yeah, let's get that child into an ophthalmologist or pediatric ophthalmologist. And then it isn't going to detect any of those neurological concerns with those. I have what are some specific ways or activities that the ENA team can do to check eye convergence? Or is there something that you should be asking parents? What are some examples of instances in which parents may see this behavior? So that's the eye convergence is tested just by really grabbing one of your assessment materials that you're already using and bringing that in towards their nose from far, and you're seeing if the eyes are going to be moving and coming together to view that object up close. And so you're just going to be watching the eyes as that's coming closer to their nose. And so you can note exactly what you see. If you see one eye deviating, if you see only one eye coming in together, if they're not moving at the same distance. And some of these are going to be, some of this stuff, even for us when we're checking vision, some of these things are really hard to detect. So you're just going to give it your best college try. And if you have concerns afterward, it's obviously something that we're going to look at more. We're going to dig in a little bit more when we do that functional evaluation. Let's see here. There's a lot of questions on here about the intrauterine drug exposure category. It's something that's noted on vision. It's not noted on hearing, but it is a concern, I think, for both. Jackie, is that?
So right. So yeah, it's not noted on there. But I think I think it's kind of the interpretation, right? So is that drug exposure, causing interruption of the blood flow, just like oxygen to the brain when the ears are developing? So I think it's kind of that interpretation, thinking more about, drugs, central issues. So I think when in doubt, right, refer, right, check it off. But I think for hearing, it's not listed specifically on that list.
Yeah. And that's just anecdotal information too.
Mm-hmm.
You can always add that in those observation boxes.
Absolutely.
Yeah. If you, I guess I would say err on the side of giving too much information than not enough. And so whatever you hear that's relevant, go ahead and plunk it on there.
And I do love the comment somebody had wrote about their kiddo who was screened every year and not diagnosed till 10. So it happens all the time. We work with the audiologist, and they have kiddos that show up, and right there they go to their kindergarten screening and this, and they're diagnosed. So, and remember, that's why these recommendations are out there for these risk factors. So we as professionals want to, do our job and make sure that we are giving the parents that information. Obviously, you can't make a parent get a child's hearing tested, but you want to make sure that they have that information, even if maybe they were given it before, and again, that just got lost in the shuffle, or they weren't, didn't hear it, whatever it was. Knowledge is power, and so if they want to check that box, great, but as professionals, it is our job to make those recommendations that are out there.
Someone asked if these need to be done for kiddos who don't qualify or kiddos we won't be serving. So the checklists are part of the evaluation process. So you should be doing them while you're also doing your evaluation to determine if a child is eligible. So yes, they are done for every child.
Okay.
Someone asked about when they can expect Britco to post the updated checklist. This is on, so the county would need to reach out to their Britco person to request that the updated checklists be uploaded into Britco.
Another one up here asks if there's a website to find local pediatric optometrist or ophthalmologist. So we personally are not able to recommend specific doctors. What we can do and what we often do is discuss, we have families who have seen this person in your area, or families who have had experience with this person. Typically, it's going to be your best bet to look on those the Children's Hospital's website. So Cincinnati Children's, Akron, Cleveland, Nationwide Children's all have information on pediatric ophthalmology, and to find individuals in your areas. And, within that, you're always going to have specialties. And so really, I think digging in and looking underneath, often those doctors will talk about their specialties and most. Infant C, also it's INFANTSEE. They have optometrists by zip code. And depending on the, on the situation that's going on with the child, we do always, if we think that there's something like a significant visual impairment, it is always our preference to start out with that pediatric ophthalmologist. But there are other resources out there, and I can pass those along also to, I can pass those on to Erica to put into the Padlet. And these are questions too that can come up during those team meetings. And so I will say, Erica, any of these questions, if we're not addressing them, or even like if we can have a printout of them, I think these are some really good conversations for us to have in the context of team, especially if there's individuals who are not able to attend today. And so we can kind of dig into some of those a little bit deeper.
Yes, absolutely. We'll save the chat.
And then I don't know if this was addressed, but somebody had wrote about the behavioral observation section. So if the child is not doing behaviors for their age range, do we backtrack? So I would say yes. So the guidance really talks about their developmental age. So right, what skills are they doing right now? So actually, Jenny and I were just talking about this yesterday, but some of it, she was kind of going back, do they have these skills, right? When do they meet these milestones? Where I was, looking at it as what are we currently doing? So yes, you definitely want to check where they are at right now. But if there's something significant, like, oh, the family says, oh, they've never done that, right? And that was a really lower skill, that could be a great observation to put down in that optional notes section.
Yes, absolutely. On the checklist, if you want to look above it, it does say to start at the age most appropriate for the child's developmental age. So if the child is developmentally functioning lower than their chronological age, then that's what we would like you to start with, looking at the observation piece.
And I just, Melissa, you asked about the agency again. It's infant C. And so it's infant SEE, and that's specifically for optometrists. So that would be more of a lesser concern, like if you notice that a child has a drifting eye, or if you're seeing some beginning stages of nystagmus. So that's when you're going to be able to find an optometrist. But if there's if you have a lot of concerns, we're going to recommend that you look first for that pediatric ophthalmologist.
So someone asked if there is a time frame for the parents to receive a copy of the checklist. The checklists are a part of the child's record. So a family can request their records at any time, but we do not require that the checklist be mailed to families. But the information lives on the IFSP and would be also in EIO3, as well as the family could request it at any time.
I'm looking through to make sure that we've gotten much of these as possible. And if not, then again, all of these questions are going to be passed on. Karen, I don't know if any of them will be in a Q&A or...
Jenny, one was just put on about they evaluated a kiddo that was 2 months old.
Oh, I do see that. We evaluated a child that was 2 months old yesterday. If a child is younger than 3 months, should we be looking for them to do what is expected at 3 months for vision? So again, that's really like a by 3 months, right? So we're looking at what are they doing by the time they reach 3 months? So yeah, check and see, are we noticing that eye contact? Are we noticing any of those social smiles? And then a lot of the other pieces are going to just be, if you notice any observations, it's with the children who are under 3 months of age, so like a 2-month-old, it's really hard to assess vision. So you're going to just be writing as much as you can. And that's where really those risk factors are going to come into play. If there's some of those risk factors, then we'll know we really want to be jumping on top of that to see what else we could be looking for down the road. And that's something, again, that you can get from your vision provider on your team. They can give you some suggestions of, look for these things when you're working with this family, or try this and see what happens. And so those are things that can happen through some of that primary coaching.
Here's one for both of you. What are some examples of screenings or tests that would be conducted by the medical community for both vision and hearing?
So I did talk about that. That was, just depending on, right, if you're having the screening or an evaluation. So that box on the checklist that talks about like your medical professionals. So, or maybe you had a speech evaluation and they do a screening. So that tool is really just more of kind of like that pass, or are we referring on for full evaluation? So it's just getting a snapshot, where the evaluation, is going to be a full evaluation. So we're going to look at, we're testing all the frequencies. We're going to look at middle ear function. We're going to look and, make sure that, right, the OAE versus the ABR. So yes, there's a lot there, but the screening is really just, do they need further testing?
And I will also, I'll add to that, if you have a child who's premature, it's always a good idea to say, were they seen for ROP? And if so, what came out of that? Children who have trisomy 21, so Down syndrome, typically they are going to be referred to ophthalmology around 6 months of age, by 6 months of age, so that they can be screened, and they look at any signs of cataracts, and they look at eye pressures for glaucoma, because both of those are very frequent among children with Down syndrome because of their facial structure. So that's also something good to know, that we usually will give a heads up during team meetings if we see a child who has trisomy 21, of, make sure that they, or find out if they have been referred to do this by 6 months of age, or if they're past 6 months of age, we'll ask if that appointment has happened, because again, that's a follow-up appointment for families that they might not see any issues, or they might not be concerned, and they might not do it. So it's important for you really to know that information, so that you can really encourage them to follow up with those appointments that are after the fact. And then someone asked if it's a possibility to have added to the guidance examples of some of the names of these screenings, like ABR, OAE, and descriptions from the parent viewpoint, so that they know how to label it. And I think too, if it's, that's something, again, we can kind of dig into a little bit later during meetings, is if there's definitions or information, because I know we live in a world of alphabet soup, and it's just, there's so much. So I do always, when I'm helping families or team members go through medical reports, I do always define and break down all of those different conditions, and try and put all of the medical jargon in English. And I do really quickly want to touch back on the one I answered about involving the neurologist if you have a child who you have concerns with. In those situations, it's an excellent idea to also get, and I know you guys do, their full medical history. A lot of times when there might not have been an ophthalmology visit or optometrist, but when we're digging through those medical reports, we find a lot of hidden information in there. So a neurologist may have noted that they suspect cortical blindness or brain-based visual impairment or something like that. And so it's really wonderful to pass those records on to, not just the vision and hearing exams, but really any of that medical information that you have, because we can kind of tease through it and pick out anything that's relevant.
And this is also about the information about those hearing assessments. Those are great questions to ask your team hearing and vision provider. They are more than willing to to give you information, more information about that, how to explain things from that parent viewpoint, what kinds of questions to ask to get the best information. They're a great resource for your team. You utilize them, ask those questions.
I was just going to say that. I mean, when we think about hearing testing, you know, there's different testing, OAE, ABR, and there's screener versus having it at the full evaluation and a combination of everything. So I think that's why, yes, and right, it would really be individualized based for that child. And again, I think that's why so often, you know, we are, okay, let's pull that testing. Because until, right, we can see exactly what testing that professional did, then we know where to go from there. Oh, and I think that we are going to be out of time because it's, somebody just said, heading to the next session. So if there's, I think, any more questions, you know, please send them to Erica and they will get answered.
Thank you, Karen, Jenny, and Jackie. That was very beneficial. Hopefully it provided some clarity to the field. Like they said, we will save the chat and loop back around to some of these questions that we weren't able to answer. I did see some questions in there regarding the Padlet. For each session today, I will post the link to the Padlet that will provide all the resources and materials for today.